Anatomical Principles of Endoscopic Sinus Surgery, a step by step approach by Renuka Bradoo. Radiological Anatomy. Don't just do something, stand there and think. Radiological Anatomy. Safe, meticulous, and complete endoscopic surgery can only be performed by a surgeon who has a sound knowledge in interpreting CT scans of the paranasal sinuses. The traditional x rays of the paranasal sinuses are all but redundant for two reasons. Firstly, the diagnosis of acute and chronic sinusitis is a clinical one. Secondly, if surgical intervention is required in either of these cases, then the information gained from an X ray paranasal sinus is too inadequate and a CT scan becomes mandatory. The CT scan is the gold standard investigation in all preoperative cases and cannot be replaced by the MRI because it gives detailed bony anatomy of the area and serves as a roadmap for the operating surgeon. CT scans are best done after a course of antibiotics so that acute inflammation is not mistaken for chronic mucosal thickening or disease. It is also advisable to ask the patient to blow his nose to clear out loose secretions prior to the CT scan. One should study the scout films provided by the radiologist first. Scout film 3 mm slice thickness. Scout film 1 mm slice thickness. Most of the anatomical details can be seen well in coronal sections. However, certain structures, example, the pterygopalatine fossa of Rosenmuller, and the optic nerve, are better seen on axial scans. A sagittal reconstruction allows us to study the anatomy of the lateral nasal wall and is especially useful to study the region of the frontal recess. Patients with dental fillings show many artifacts in coronal sections. In such cases, axial films can be taken and coronal reconstructions obtained. A very basic paranasal sinus study would include bony and soft tissue windows of 3 mm cuts taken anterior to posterior in the coronal plane. However, certain cases, example optic nerve injury or CSF rhinorrhea, would require 1 mm cuts for adequate evaluation. The coronal sections are routinely read from anterior to posterior and the axial sections from inferior to superior. Coronal scans. The most anterior cuts show the frontal sinus and the nasal bones. The frontal sinus shows great variation in pneumatization. The interfrontal septum is in the midline inferiorly but may deviate to either side of the midline as it goes posterior superiorly to attach to the posterior wall of the frontal sinus. The interfrontal sinus septum may at times be pneumatized. Septae within the frontal sinus may lead to the formation of deep lateral recesses. The multiple frontal septae show a classical scalloping of the frontal sinus, which is lost in cases of mucocele. Anterior cut showing frontal sinus and nasal bones. Cut showing the interfrontal septum, scalloping of frontal sinus. The inferior turbinate is visualized. Any hypertrophy of the inferior turbinate is looked for. A mucosal swelling is seen in the anterior part of the septum. This is the septal tubercle, which consists of erectile tissue and is phylogenetic remnant of the vomeronasal organ. The septum should be studied for deviations and septal spurs. The middle turbinate is not yet seen. The air cells in this region are the agar nasi cells. The nasolacrimal duct is visualized. The presence of frontal cells, type 1 to type 4, should be looked for. The middle turbinate is visualized. Any anatomical variations like concha bullosa, and or a paradoxically curved middle turbinate should be looked for. Here we can see the septal tubercle, and here we can see the agonized cells, the nasolacrimal duct, the middle turbinate which is not yet visualized. The attachment of the middle turbinate at the junction of the medial and lateral lamellae of the cribriform plate is seen. The level of cribriform plate and the depth of the olfactory fossa should be assessed and classified according to the Kiros classification. The height of the ethmoidal fovea above the level of the cribriform plate is noted. Pneumatization of the crista galli may be visualized. The ethmoid bulla is seen lateral to the middle turbinate. If the ethmoidal bulla does not extend to the skull base, the suprabullar recess may be visualized. A cell extending above the orbit behind the frontal sinus may be seen in this cut. This is the supraorbital cell which drains into the suprabullar recess. Olfactory fossa, anterior attachment of the middle turbinate is seen. The ethmoidal bulla and supraorbital cell has been seen. The uncinate process is seen below the bulla. The groove between the uncinate process and the bulla, that is the hiatus semilunaris and the infundibulum, are seen leading into the normal maxillary ostium. This is the osteomeatal unit. It should be noted whether any of the septal spurs impinge upon or compromise the osteomeatal unit. Hypertrophy of the turbinates or a concha bullosa on the side opposite to the septal deviations should be looked for. The mode of attachment of the uncinate process should be carefully studied so as to ascertain the pathway of drainage of the frontal sinus. Variations in the anatomy of uncinate process and the presence of Haller cells should be looked for. The osteomeatal unit. A close-up view. We can see the uncinate process, maxillary ostium, infundibulum, hiatus semilunaris, middle turbinate, and the ethmoidal bulla. Drainage of the frontal recess, medial to infundibulum on the right and into the infundibulum on the left. Accessory ostia may be seen in the region of anterior and posterior fontanelle. The maxillary sinus is seen. It is triangular in shape in this section. The infraorbital nerve is seen in the roof of the maxillary sinus. At times it may be dehiscent. 2 to 3 millimeter behind the bulla, the anterior ethmoidal artery is seen as a classical beaking of the medial orbital wall. The anterior artery may lie close to the skull base or may cross low within the anterior ethmoids, in which case the orbitocranial canal with its bony mesentery is clearly seen. Accessory ostium in the left posterior fontanelle. Maxillary sinus appears triangular in anterior cuts. Arrow showing the infraorbital nerve. Anterior ethmoidal artery. Beaking of lamina papyracea seen on the left. Orbitocranial canal seen on the right. The middle turbinate is attached to the lamina papyracea by its ground lamellae. The lamella is seen separating the anterior ethmoidal cells from the posterior ethmoid cells. The superior turbinate is visualized in the more posterior cuts and variations in it, example pneumatization, paradoxical curvature should be looked for. The posterior attachment of the middle turbinate to the palatine bone is seen. The posterior ethmoid cells are larger and fewer than the anterior ethmoid cells. The posterior ethmoid artery may occasionally be identified in the region of the skull base. The maxillary sinus changes shape from triangular to ovoid in more posterior cuts. The orbit changes from a circular outline to a triangular or pyramidal shape. The posterior part of the orbit with the extraocular muscles and the optic nerve is seen. The fissure between the orbit and the maxillary sinus, that is, the inferior orbital fissure, is seen in this section. The infraorbital fissure opens laterally into the infratemporal fossa. It is important to know that the medial rectus is separated from the lamina pepracia by a pad of fat anteriorly. However, more posteriorly in the orbit, this pad of fat is absent, and the medial rectus is in direct relation to the lamina pepracia and therefore more prone to injury. Here we can see the ground lamella in arrow, the intermediate attachment of the middle turbinate. Here we can see in the arrow posterior attachment of the middle turbinate. And last diagram we can see the posterior ethmoid cells, inferior orbital fissure. The sphenoid sinus is seen in the more anterior cuts. Both the posterior ethmoid cells and the sphenoid sinus are seen. The superolateral cell is the posterior ethmoid cell, whereas the inferomedial cell is the sphenoid sinus. The more subsequent cuts shows the sphenoid anatomy more clearly. The sphenoid dominance should be noted when the intersphenoid septum is asymmetrical. The sphenoid sinus ostium may also be visualized through this is better seen in sagittal cuts. Accessory septae, which within the sphenoid, should be looked for and traced to see if they are attached to vital structures. The optic nerve and the internal carotid artery are studied for any dehiscence of the overlying bone. Pneumatization of the anterior clinoid process leading to an almost bare optic nerve protruding into the sphenoid sinus should be looked for in the presence of an Onodi cell superior lateral to the sphenoid cell. Special attention should be paid to the course of the optic nerve. The extent to which the pituitary bulges into the sphenoid sinus will depend on the extent of pneumatization. This is best appreciated in the sagittal reconstructions. In the diagrams, we are seeing fat intervening between lamina pepraceae and medial rectus anteriorly. Medial rectus in direct contact with lamina pepracea posteriorly. Bilateral sphenoid ostia. The retort-shaped orbital apex is seen on either side of sphenoid sinus in the anterior cuts. The pterygoid process extend downwards and are perforated by two canals. The first is the foramen rotundum, which is seen just below the orbital apex. Inferior medial to this foramen is the opening of the Vidian canal. The pterygoid processes from the posterior wall of the pterygopalatine fossa. The pterygopalatine fossa itself is the best seen in the axial sections. A canal may be seen between the sphenoid sinus between the pterygopalatine fossa and the posterior choana. This is the sphenopalatine foramen, which opens above the posterior end of the middle turbinate. The sphenoid sinus may extensively pneumatize the pterygoid process and the greater wing of sphenoid to produce a large lateral recess extending between the foramen rotundum and Vidian canal. Here we can see two diagrams, orbital apex shown in arrow, sphenoid dominance on the left, pterygoid process shows by P. Vidian canal is a thin arrow, foramen rotundum thick arrow, and optic nerve the curved arrow. Coronal sections of the nasopharynx shows the aeration tube opening, the torus tuberous, the fossa of Rosenmuller, and the adenoids, if present. Asymmetry of the fossa of Rosenmuller should be looked for. The foramen ovale is seen laterally in the greater wing of sphenoid. Widening or destruction of the foramen should be looked for in a case of nasopharyngeal angiofibroma or carcinoma of nasopharynx, respectively. Sphenoid foramen shown in arrow, torus tuberous, fossa of Rosenmuller, and adenoids. Aeration tube EO and foramen ovale. Axial scans. Certain structures are well seen on axial cuts. The nasolacrimal duct is seen as a circular opening at the anterior medial corner of the maxillary sinus. Its anterolateral walls are thick, whereas its medial wall is comparatively thin. Anterior posterior deviations of the septum can be assessed. The nasopharynx can be studied well in axial cuts, and asymmetry of the fossa of Rosenmuller can be looked for. An axial section through the middle turbinate will show its ground lamella and its attachment to the lamina pepracia. The anterior ethmoid cells can be demarcated from the posterior ethmoidal cells on the basis of this ground lamella. The space between the bulla and the ground lamella, that is, the retrobullar recess, when present, can also be seen in axial sections. We can see the nasolacrimal duct given in arrow, fossa of Rosenmuller given in arrow, aeration tube opening, the ground lamella shown in arrow, G ground lamella, B bulla, R retrobullar recess, U uncinate process. The maxillary sinus, the medial and lateral pterygoid plates, and the intervening pterygopalatine fossa can be seen. The pterygopalatine fossa opens medially into the nose via the sphenopalatine foramen. Laterally, it opens into the infratemporal fossa. The anterior, posterior, lateral, and medial walls of the maxillary sinus can also be studied in the axial cuts. The roof and the floor of the maxillary sinus are better studied in coronal sections. The lamina pepracia runs a fairly straight course in an anterior posterior direction. However, in lower cuts of the orbit, the upper part of the maxillary sinus is also seen, and hence the lamina pepracia appears to take an abrupt curve laterally into the orbit. Any natural dehiscence in the lamina should be looked for. Axial dehiscence, axial sections gives an excellent opportunity to study structures in the orbit. That is, the medial and lateral rectus, the intracoronal cornal, and the extracornal and preseptal compartments. The optic nerve can be traced in its entire course, and its relation to a pneumatized anterior clinoid process or Onodi cell can be ascertained. The orbit in axial section, the lamina pepracia in lower section of the orbit. The sphenoid sinus can be examined for asymmetry. Dehiscence over the internal carotid artery is better appreciated in axial cuts than in coronal cuts. The cavernous sinus can be seen on either side of the sphenoid sinus. It is better studied after injection of contrast. The cribriform plate, crista galli, foramen cecum can be studied in 1 mm sections. Anterior to the cribriform plate is the frontal sinus. The anterior and posterior walls of the frontal sinus are better appreciated in axial than in coronal sections. Crista galli, the thick arrow, and the foramen cecum with the thin arrow. Sagittal sections. The sagittally reconstructed section gives an excellent opportunity to study details of the lateral nasal wall anatomy. The four lamella that the endoscopic surgeon has to cross in an anterior posterior direction are well seen in a single cut on the sagittal section. Here we can see the sagittal reconstruction seen in CT scan. Schematic representation of the sagittal CT scan. We can see the frontal cell, frontal sinus, agar cells, hiatus semilunaris, uncinate process, middle turbinate, inferior turbinate, bulla. We can see the sphenoid sinus, sphenoid ostium, pituitary gland, clavus. So the four fontanelle that the endoscopic surgeon has to cross in an anterior posterior direction are well seen in a single cut on the sagittal section. The anterior and posterior ethmoids and sphenoid sinus are well demarcated from each other on the basis of these lamellae. The retrobulbar and the suprabulbar recess, that is sinus lateralis, if present, can also be seen. It is especially useful to study anatomy of the frontal recess area and should be asked for prior to operations on the frontal sinus. Pneumatization of the sphenoid in relation to the pituitary fossa can also be studied prior to pituitary surgery. The sphenoid sinus ostium is also seen on sagittal cuts. The extent to which an Onodi cell has migrated over the sphenoid sinus can be accessed on a sagittal scan. Usually, only a plain CT scan is study is necessary. Contrast enhanced CT scans of the paranasal sinus are reserved for cases such as tumors and suspected pyoceles. CT cysternography may be used in cases of CSF rhinorrhea. However, a combination of plain CT with T2 weighted MRI images is a better non invasive option. MRI scans are useful in cases of tumors, especially to detect intracranial from extensions, involvement of soft tissues of the face, and to differentiate tumors from secretions. They are also indicated in cases like optic nerve injury and fungal infections of the paranasal sinuses, where they give a classical signal void in T2 images. 3D reconstruction scans help in cases of tumors and craniofacial anomalies. Other radiographic techniques available in our diagnostic armamentarium are the MRI angiography, digital subtraction angiography, and the dacrocystography. The MR angiography has the advantage of being non invasive, but digital subtraction angiography becomes necessary if any intervention is required in vascular lesions. Although we can garner a wealth of information from a plain CT paranasal sinus, it sometimes becomes necessary to ask for more advanced investigations to reach a complete diagnosis. Thus, there is an almost bewildering range of technologically advanced investigations available to the endoscopic sinus surgeon. It requires a judicious surgeon to pick and mix and match these investigations in such a way that he gains the maximum information possible at a reasonable cost to the patient. Next, we'll be learning about the anatomical variations. Thank you.